So this is such an important topic because it's never talked about. It's horrible and very distressing for patients even to raise in clinic, even with a doctor that they know very well, because it's so embarrassing. I mean, fecal incontinence is the loss of fecal material poo involuntarily, and that can cover anything from a little bit of seepage or stain on the underwear through to a very urgent call to go to the loo and not being able to, as it were, wait until you actually get there, or sometimes very distressingly to almost involuntary incontinence if the sensation or loss of muscle control doesn't allow you to actually keep control of your bowels, which results in literally in accidents unpredictably. And these are very distressing symptoms that are very difficult to talk about. So it's a really important area, and it's a really important area to bring up with your physician or surgeon because usually something can be done to help with it. It's usually pretty obvious if you've got a problem. You may not notice a small amount of seepage until you sort of undress or look at your underwear at the end of the day. But it can be fairly low grade in terms of a little bit of seepage of fluid or fecal material. But equally, it can be that you noted that there's passage of feces involuntarily. Just occasionally, people have problems with their sensation. So unfortunately, it can happen without the patient being aware of it. But that's relatively rare. Normally, people know if it happens. It's really important to trust the doctor with this intimate knowledge and to share the symptoms because otherwise, dreadful symptoms can go unaddressed for a long time. The first thing is that incontinence can sometimes be a sensation of leakage down below, and it's not always obvious whether it comes from the front passage or the back passage. And people shouldn't be embarrassed about this because it's not always straightforward. Of course, if you're bleeding vaginally or you have some urinary leakage, then that might need to be addressed either to a gynecologist or to a urologist. That's a specialist in sort of waterworks. So my particular area as a gastroenterologist is dealing with leakage or incontinence from the back passage. This is so much more common than you might think. Surveys have shown that up to 1% of adult women experience incontinence, fecal incontinence, one in every 100. So if you're in a room full of people, if you're in a room full of 100 people, the chances are that, you're not the only one that's suffering from this really very distressing symptom. So it does really need to be don't feel the message is not to feel embarrassed about talking about it because often help is at hand. Like any medical condition, a proper diagnosis starts with a careful history and examination. So you can expect the medical professional to ask you some pretty intense and personal questions designed to try and reveal the symptoms, whether or not you leak a bit of fluid or whether you actually leak solids and stuff like that. And then an examination would begin in the consultation room with an abdomen examination, usually an examination of the back passage as well. Although this might be delayed until a slightly more formal setting if you have an endoscopy. So it depends really, and often patients aren't always completely comfortable to have an examination. They may need a chaperone, and they may feel more comfortable in a formal examination or clinic, like an endoscopy setting, really. And it's incumbent on the medical professional to make sure that the patient feels as comfortable as possible before they have that. Then there are a series of procedures that might involve ultrasound or X-rays or imaging to try and find out what's going on. And there will often be a series endoscopy, which is a camera exerted in the bottom to find out what's going on, and there. And that usually allows us to make a diagnosis of what's going on. In some cases, there's a test called anorectal physiology, which is a bit of a plumbing test, really, involving measuring what the muscle strength is, and it can involve some technology, and sometimes a small balloon being put in to measure the strength of your muscles to see if there's any weakness or any signs of damage there. These tests are always, or should always, be fully explained and discussed with the patient, so they shouldn't come as a particular surprise. So the tests will be very carefully tailored to what the presenting symptoms are. Surgery is one of the possibilities of treatment. It's absolutely not a routine part, but if, for instance, I mean, very commonly, fecal incontinence in females is a result of damage to the sphincter muscles, often sustained at childbirth. And these sphincter muscles could have been torn or damaged, and consequently, it's sometimes possible to offer a surgical repair, which can be really, if there's a definite, sort of a gap because the muscle's been torn, then surgery is one potential way of repairing it. So surgery, it is a part of the options. It doesn't always mean that surgery is needed, but it can form part of the available option of treatments and solutions for this very distressing symptom.